Hello, ladies and gentlemen. Today we're going to continue our series of lectures on anesthesia by talking about the drugs used in anesthesiology. This slide shows a summary of the agents we're going to talk about. These include gases, vapors, induction drugs, muscle relaxants, reversal agents, opioids, antiemetic drugs, sedative drugs, and local anesthetics. So a lot of material to be covered. The only gas that's used in anesthesia is nitrous oxide. And what we mean by gas as opposed to vapor is that it's a gas that in gas form at normal room temperature. So it's normally in a gas form, and the only time it's ever in a liquid form is when it's under very high pressure. Nitrous oxide is a weak anesthetic, and it must always be supplemented with other anesthetic drugs, except in those very rare situations where patients are in a dive chamber and having anesthetic in a dive chamber where the atmospheric pressure can be increased, and then nitrous oxide becomes a reasonable anesthetic. Nitrous oxide is very insoluble in fat, which means that it has a rapid onset and a rapid offset of effect. It's an excellent analgesic without having narcotic-like properties. It's often used in labor analgesia and in the emergency room for minor procedures, but it's disappearing as a mainstem anesthetic agent in modern practice, partly because it causes gas to form in the gut and other areas of the body where there's gas spaces, and this can lead to problems with healing, and in the case of the gut can lead to leak of anastomosis. The low fat solubility causes the gas to diffuse into these gas spaces in the body, such as the middle ear and the gut, and this is an issue that is of concern. So we're not using it as much as we used to. More commonly, we use vapors, and vapors are drugs that are a liquid at room temperature, but which is partially diffused into the atmosphere. Exactly the same principles that are associated with water vapor, which is all around us all the time. Anesthetic vapors are calibrated to be released in a known concentration into the patient's circuit. The first widely used vapor was ether. And ether was very safe because it was not very potent in reality. It was very soluble in fat, and it was relatively low potency, and it lasted a very long time. The only anesthetic I've ever had was an ether anesthetic when I was about 5 years old, and I had my tonsils out, as everybody did in that era. And they had two big men in the room that were there just to hold the patients down while they were breathing ether. I was 5 years old. I didn't think I had a lot of mass to hold down, but they still needed to have these men in the room to do it. Very slow onset, very slow recovery, often severe nausea and vomiting, no anesthetic properties at all, no analgesic properties at all, no pain-killing property whatsoever. But despite that, it was quite safe. And it's still used in some developing countries. Modern vapors are designed to have much lower fat solubility and have much more rapid onset of action than ether, and also much more rapid recovery and less hangover effect than ether used to cause. The most modern drugs, desflurane and sevoflurane, are the best in this respect. Those drugs that came after ether, such as halothane, methoxyflurane, enflurane, and isoflurane, have largely disappeared from practice, although isoflurane is still occasionally used. With methoxyflurane, it was possible to measure methoxyflurane in fat stores up to a year after an anesthetic had been given. With desflurane and sevoflurane, measuring for those drugs in fat stores, they're absent within 24 hours. So sevoflurane is a commonly used modern vapor anesthetic. It has a sweet smell, which is well tolerated by patients, so it can be used instead of intravenous induction drugs in patients with needle phobias or with very poor venous access. It's also very popular in pediatric anesthesia because children are not as terrified by a mask as they are by a needle. Even when used by inhalation, it has a rapid onset, and recovery is also quite quick, but not as fast as you'll see with desflurane. It has no analgesic properties whatsoever, and it can, like all vapors, cause nausea and vomiting. Desflurane has a very rapid onset and recovery and little hangover, but unfortunately it's unsuitable for inhalation induction because it has a very pungent smell, and people who breathe it tend to gag and are very uncomfortable, so we don't use it that way. It's very fat insoluble. In fact, it basically is as fat insoluble as nitrous oxide. It's the closest thing to nitrous oxide in terms of its fat solubility of any of the vapors. Patients usually wake up clear-headed, but it can still cause nausea and vomiting. And again, it has no analgesic properties. So modern vapors, such as sevoflurane and desflurane, have rapid onset and rapid recovery and less hangover than older vapors. But they do produce profound amnesia even in very low doses. And amnesia is critical to anesthesia, to general anesthesia. They do have respiratory and cardiovascular effects that we've already mentioned, and these must be monitored. They can produce nausea and vomiting, and they can trigger malignant hyperthermia, which we will talk about in another slide. They have little or no analgesic effects, so all of these drugs require augmentation by analgesics. Induction drugs are the drugs that we give intravenously to help people go to sleep. And the bottom line with induction drugs is that they have to be rapid onset and pleasant. And they should wear off fairly quickly so that the patients can be turned over to vapors as soon as possible. Thiopentone is the classic induction drug, and it's been used since Pearl Harbor, basically, December 7th, 1941, when it was widely used after the attack on Pearl Harbor. And perhaps apocryphally, it's often stated that more U.S. soldiers died from pentothal than they did from Japanese bullets. I think that's probably unlikely, but it was the first time it was widely used, and it was a very potent drug and potentially very dangerous, and they didn't know how to use it. Propofol, which is the cardiologist's drug of choice, if you think of Michael Jackson or Joan Rivers from the ENT surgeon, this is a drug that has become extremely popular, but can be horribly mismanaged by people who don't understand how to use it. It's the commonest modern induction drug. It has a very rapid onset, although not quite as fast as pentothal, but a more rapid recovery than pentothal and much less hangover than pentothal. It also has some antiemetic effects, so it produces little nausea and vomiting, and in fact, we can actually give it as an antiemetic during the surgery. It does, however, produce myocardial depression, as does pentothal. Unfortunately, propofol also produces decreased vascular resistance, causes dilatation of peripheral blood vessels, so profound hypotension is not uncommon during induction with this drug. It's not suitable for unstable patients. It is, however, useful as an intravenous sedative, or it can be used as the primary anesthetic without a vapor. This is known as total intravenous anesthesia, or TIVA. Ketamine we mentioned briefly previously. It can also be used as an induction drug. It actually is an effective analgesic, which none of the other induction drugs are, but it does produce that emergence phenomena I mentioned to you. It supports cardiovascular function by increasing heart rate and blood pressure moderately. It's often used in unstable patients, and the emergence phenomena can be reduced by adding a benzodiazepine such as lorazepam or midazolam late in the case. Etomidate is also an induction drug, and it's been used in the U.S. since 1975, but in my country, Canada, it's only been used since 2005 because of the very small market for it in Canada. It supports cardiovascular systems in trauma patients, but causes adrenal suppression. And some recent studies have suggested that there's an increased death rate in patients who receive etomidate with no evidence during the surgery itself that it's causing any risk. But it may be useful in patients with brain trauma because it does maintain cerebral oxygenation and cerebral blood flow at the time of induction. And yes, we do paralyze patients. Modern muscle relaxants are rapid in onset, predictable in recovery sequence, and have minimal cardiovascular effects. But they produce no amnesia and no analgesia. And one of the great errors that occurs in anesthesia is to think that a muscle relaxant is an anesthetic. They're used primarily in surgical procedures where muscle relaxant is necessary for adequate surgical access. This is most commonly abdominal surgery, thoracic surgery, and surgery on heavily muscled areas such as the thigh. They're also used so the anesthetist or other physician can secure the airway with minimal trauma to the patient. It paralyzes the muscles of the airway, allowing the vocal cords to remain open, and makes it easier to place an endotracheal tube. It's often used in patients who require prolonged ventilation in the operating room or in the intensive care unit. They prevent movement. They prevent breathing. They prevent escape. The patients can't get away, but they do not produce analgesia, and probably even more importantly, they do not produce amnesia. Do not produce sleep or unconsciousness directly. So they are not anesthetics. They are adjuncts to anesthesia, and their use in the absence of drugs that cause amnesia or drugs that produce analgesia is very bad practice. One of the nice things about muscle relaxants is that amongst all the drugs used by anesthesiologists, they're about the only drugs we actually know exactly how they work. They either cause depolarization of muscle fibers in what is referred to as an irreversible action. This is the depolarizing muscle relaxant succinylcholine. Or they competitively block depolarization of muscle fibers by competing with normal neurotransmitters, non-depolarizing muscle relaxants. And the newest of all of these is rocuronium. So depolarizing muscle relaxants actually pass across the neuromuscular junction to the muscle end plate and cause depolarization of the muscle. In other words, they act as if they were a normal neurotransmitter and cause normal contraction of the muscle. However, this contraction is brief, and we refer to it as fibrillations when we can see the twitching of the muscles, and it's irreversible. The drug just sits there and doesn't allow the muscle to repolarize, which is the normal sequence in normally functioning muscles. Now, that's not to say that it stays forever. It tends to get diluted over time in normal body fluids, and there is a substance in most people called pseudocholinesterase, which will break down succinylcholine and get rid of it in a really quite rapid fashion. However, we'll talk briefly about this in another lecture where people do not have pseudocholinesterase. The more commonly used drugs now are non-depolarizing muscle relaxants, so they don't cause the fasciculations that you get with succinylcholine. And what happens with them is they pass across the neuromuscular junction, they attach themselves to the neuromuscular end plate, and they sit there for a period of time, but they're in competition with acetylcholine, which is the normal neurotransmitter. Anything that tends to increase the concentration of acetylcholine will reduce the effect of the muscle relaxant. Anything that tends to reduce the effectiveness or the presence of acetylcholine will increase the effectiveness of the muscle relaxant. And this is kind of a diagram of how these drugs work. They change the polarization of the neuromuscular sarcolemma, the surface of the muscle, so that there's a movement of sodium and potassium in opposite directions, and there's a change in polarity, which results in an action potential. Acetylcholine does this by opening up channels that allow depolarization of the muscle fiber. Non-depolarizing muscle relaxants block the effect of acetylcholine by competing for those same receptors. And succinylcholine causes depolarization, but it doesn't allow repolarization. And without the cycles continuing, depolarization and repolarization, no further contractions can occur. So succinylcholine, the only commonly used depolarizing muscle relaxant, irreversibly blocks access to the muscle end plate by acetylcholine. This causes a short phase of depolarization of muscle fibers, characterized by muscle twitching or fasciculations. Succinylcholine has a very rapid onset of action and produces very profound paralysis in all voluntary muscles. Under normal circumstances, it's metabolized by pseudocholinesterase in under 18 minutes. Unfortunately, a common side effect of this drug is myalgia, pain in the muscles. And this is similar to the kind of pain one gets from exercising very vigorously when you're not fit. And the next day you can barely move. Well, succinylcholine produces exactly the same kind of feeling in the muscles. And patients often will phone the doctor, the surgeon, and complain they feel like they've been hit by a truck. So it's very unpleasant. The other issue with succinylcholine, there are a number of issues with succinylcholine, but another issue is it releases histamine, and this can induce asthma attacks in patients who are susceptible. In patients with spinal cord injuries, massive trauma, burns, and renal failure, succinylcholine can cause the release of huge amounts of potassium into the bloodstream, and hyperkalemia causes cardiac arrest. And this is obviously an extremely serious complication. It also increases intraocular pressure. So in patients who have eye injuries, it can actually cause significant damage at the time of induction. It causes increased intracranial pressure. So in somebody who has an intracranial bleed or a brain tumor, this can be a problem. It causes increased intragastric pressure, and this can lead to vomiting, particularly at the time of induction, which isn't really vomiting. This is regurgitation, and aspiration can occur with damage to the lungs. And like the vapors, this drug triggers malignant hyperthermia, and we will talk more about this very rare but very serious genetic problem in another lecture. So it does trigger malignant hyperthermia in susceptible patients. About 1 in 1,000 patients are genetically pseudocholinesterase deficient and cannot metabolize succinylcholine and will have a markedly prolonged block from the drug. These patients should not be given succinylcholine. And about 1 in 500 patients have an abnormal pseudocholinesterase, which metabolizes succinyl slowly. And the only way you can actually determine whether this is happening is if you're using a neuromuscular monitor and watching neuromuscular recovery constantly. So it's not unusual for that patient who doesn't metabolize succinylcholine properly to get a second dose of another muscle relaxant, which can confuse the whole issue. Drug is losing favor with anesthesiologists and is largely saved for trauma patients or unstable patients who require profound and rapid paralysis to allow airway management. I've only used this drug about 3 times in the last year. The non-depolarizing muscle relaxants are all relatives of the early arrow poison curare, from the Amazon area, where the Amazon natives used curare to shoot monkeys, and the monkeys were then taken and they were part of the food supply. And curare worked by causing generalized paralysis in the monkeys, and because they couldn't breathe, they couldn't survive. Subsequent to curare, a number of drugs have been developed, and the slide here kind of shows the order in which they came on the scene. So curare, galamine, pancuronium, vecuronium, atracurium, cisatracurium, mivacurium, rocuronium are the kind of sequence with which these drugs were marketed. They all compete with acetylcholine, so the concentration of the drug relative to the concentration of acetylcholine determines the degree of paralysis of voluntary muscles. Each of these drugs has its own characteristics so that they vary on speed of onset, duration of action, and effects upon the cardiovascular system and whether or not they release histamine. When first injected, they cause complete paralysis because the competitive balance with acetylcholine favors the muscle relaxant. We inject a lot of muscle relaxant. As the surgery progresses, the muscle relaxants are washed away, become diluted in normal body fluids, and are excreted primarily unchanged in the urine, and acetylcholine takes over. Therefore, it is often necessary to repeatedly inject muscle relaxants, non-depolarizing muscle relaxants, to maintain surgical paralysis. And believe me, the surgeons tell us when they think more paralysis is necessary. The balance between acetylcholine and muscle relaxant can be changed by giving an acetylcholine esterase inhibitor. These agents prevent the metabolism of acetylcholine by locally produced acetylcholine esterase, thus shifting the competitive balance towards recovery of muscle activity. So normally, acetylcholine is released from the at the nerve ending, passes across the neuromuscular junction to the muscle end plate, causes depolarization, and then is rapidly broken down by acetylcholine esterase. What we do as anesthesiologists is we block the effect of acetylcholine esterase, thus blocking metabolism of acetylcholine, increasing the concentration of acetylcholine, and overcoming the effect of the non-depolarizing muscle relaxant. This is rocuronium, which is the newest of the non-depolarizing muscle relaxants. It has a rapid onset of action, about 75% seconds in higher doses, which isn't quite as fast as big doses of succinylcholine, which usually work in anywhere from 45 seconds to 60 seconds. Rocuronium has a short duration of action, around 20 minutes in regular doses, but as high as an hour when we give large doses. It produces no histamine release. It produces no fasciculations or myalgia. It has no effect on the cardiovascular system. But it does have side effects. And the most important of these is residual paralysis. So this is the patient who wakes up at the end of his or her surgery and continues to have weak muscles. The other problem with rocuronium is that it requires normal or near normal renal function for it to be excreted. And in patients with abnormal renal function, it tends to accumulate, and then it's very difficult to reverse. The relaxation we get with rocuronium is not quite as profound as with succinylcholine, so that if you're in a hurry or if you need really profound relaxation, most anesthesiologists favor succinylcholine. It does not, however, trigger malignant hyperthermia. So the reversal agents that we most commonly use are neostigmine, edrophonium, and pyridostigmine. And all of these drugs are acetylcholine esterase inhibitors. They prevent the breakdown of acetylcholine in the neuromuscular space. We'll talk about sugammadex in a moment, which is a newer drug, which forms a new compound with rocuronium, thus taking rocuronium out of the system and rapidly reversing its effect. Acetylcholine esterase inhibitors act upon nicotinic receptors, skeletal muscle, and muscarinic receptors, which produce all the effects from the vagus nerve. So gut activity, salivation, bronchomotor smooth muscle tone, all those sorts of effects that the vagus produces. And unfortunately, acetylcholine esterase inhibitors aren't smart enough to only reverse nicotinic receptors. They also reverse muscarinic receptors. So that we always add an anti-muscarinic drug along with the reversal agent to prevent some of those side effects. So those drugs are usually atropine, which is very rapidly acting, and glycopyrrolate, which is actually a better match with neostigmine. And these help avoid excessive airway and salivary secretions, severe bradycardia, which can be caused by excessive vagal stimulation, and induction of an asthma attack. So we're going to talk a little bit about sugammadex now. It's a new agent that works by combining irreversibly with rocuronium. It has a very rapid onset, and it can be given at any time rocuronium has been given. So there's no delay in its responsiveness, whereas with the acetylcholine esterase inhibitors, you usually have to wait with rocuronium about 20 minutes before they have any effect. With Sugamidex, you can give it right after you give the rocuronium, and it'll rapidly reverse the effect of the rocuronium. It's not available in North America, but it's available in Europe and in Japan and in parts of South America. Unfortunately, its cost may limit its use by anesthesiologists. And this is the chemical structure of Sugamidex. And think of it more as a donut with an outer ring that is polarized and a central hole in the donut which is very lipophilic, so it sucks lipids in. And this is kind of what it looks like. On the far right is an imaginary representation of rocuronium. The middle slide is the Sugamidex. See, the hole in the middle is the lipophilic portion, and the slide to the far right is the combination of Sugamidex and rocuronium, where the lipophilic entity of rocuronium, which is a steroid nucleus, is sucked into the Sugamidex core, and the outer rim of the Sugamidex has been modified so that it is polar and has arms that are opposite and equal to the polar arms on the rocuronium. So the total effect is just to lock this rocuronium into an irreversible combination. So it's an irreversible combination, as I mentioned. Very rapid onset, around a minute. Whereas neostigmine, as I mentioned, the peak effect of neostigmine, even in somebody who can be reversed, is around 8 minutes. And it takes as long as 18 minutes to actually reverse the effect of rocuronium. Sugamidex has no effect on muscarinic receptors. It appears to have a very clean side effect profile. It'll reverse even very large doses of rocuronium in about 75 seconds or less. But it's not available everywhere in the world, and it's expensive. So let's just review this presentation. We talked about vapors. We talked about induction drugs. We talked about gases, nitrous oxide. We talked about muscle relaxants and reversal agents. And we ultimately talked about Sugamidex and its effect on relaxation of rocuronium, but only rocuronium. As you can see from this presentation, there are many drugs in anesthesiology, and they are complex. And they often interact in ways that are unexpected and can cause, side effects that are unpleasant and have to be dealt with and anticipated. So one of the duties of an anesthesiologist is to use these drugs in a safe fashion with full knowledge of how they work, in those cases where we really know how they work, and what to expect in terms of side effects, and to do the best in his or her ability to reduce those side effects.